the founder and past director of the Mansoura Manchester program. Professor Abdel-Hady will talk today about one of the important topics, because as you know, caring of dialysis is not nephrologist. Caring of dialysis, the patient is patient. So all specialties should collaborate together for the welfare of these fragile patients. And although it is not common to find a lady pregnant, but obstetric problems, gynecological problems, and infertility are common and troublesome for dialysis patients. So today we have the two aspects or two perspectives. We have the obstetrician perspectives that will be covered by Professor Abdel-Hady, and the nephrological aspects and the perspectives would be covered by eminent Professor Ashraf. So I think it will be very nice and stimulating session. Professor Said.
Thank you very much, Dr. Hussein. Good afternoon, ladies and gentlemen. It's my pleasure to be with you for the second time. And I'm going to address obstetric aspects of chronic renal disease as the domain of the exposure for dialysis and renal failure. So, once again, you are very welcome in Mansoura, and you are always welcome in this institute, and we will find a way to make it possible for everybody who is wishing to come to Mansoura an easy job. So the objectives of this presentation is to address these four topics. Number one, what are the chances of pregnancy in women on dialysis or in chronic renal failure? The second question is, should a woman on dialysis become pregnant if you are looking after a lady in the childbearing age? And to ask you, doctor, is there any chance for me to become pregnant? And the next question is, what are the complications of end-stage renal disease on pregnancy? And if she comes pregnant, what are the complications and how to manage such complications? That's not far away. In 1975, in The Lancet stated that children of women who with renal disease used to be born in a dangerous condition, not at all. Not at all means that they will never be born alive, especially if the doctors don't know their way, if the doctors are not trained to manage pregnant women with renal failure. Now, I think, as you all know, the situation is very different. So, just 30 years or 35 years, now these women usually have transplant and the graft is working properly and they can get pregnant with no problems. But the problem is if they get pregnant while on dialysis. But there is another aspect. If these women get pregnant after renal transplant, and I would assure that they are close to the normal population if they have normal kidney function and good graft. But if they have renal failure, if they are on dialysis, definitely the prognosis is not as good as for other women. Is it uncommon for renal disease during pregnancy? End-stage renal disease or renal failure is uncommon. But other conditions of kidney disease are quite common. So in obstetrics, we see quite women with chronic renal disorders, but not necessarily renal failure. Now we see more women with renal transplant than more women with renal failure, because, as you know, in this center and other centers, they are quite clever in doing transplant. This also is not correct that the successful pregnancy outcome is not uncommon in women recurrent chronic renal disease. He wants to say that in a study journal, to get a pregnancy uneventful with a live baby is a rare event in chronic renal disease. All this background says something that is not an easy situation when you are managing a woman with chronic renal failure and she becomes pregnant. The other aspect of this talk is after successful renal transplant, almost all these women can have a normal outcome. So the advice, even if this woman is faced with problems during the pregnancy, is to advise for a renal transplant. We're going to study this case just to elucidate or illustrate what happens with these patients. This is a 20-year-old lady, recently married, and she has chronic renal failure due to lupus nephritis, which is common. By the way, lupus erythematosus or systemic lupus is a common complication of pregnancy, and per se, systemic lupus has many adverse effects on the outcome of pregnancy. If added to that renal failure, the prognosis is usually poor. She was on hemodialysis waiting for a transplant, but she got pregnant. And the pregnancy was in utero and progressing normally. In the first visit, her blood pressure was 140/90 and hemoglobin is less than 10. One of the very important parameters in managing this woman is the hypertension, creatinine level, and proteinuria. These are the three markers that we look through. If you start pregnancy with hypertension, with raised creatinine and significant proteinuria, definitely the prognosis is not good. And this lady was counseled regarding either to terminate pregnancy or to carry on, and counseled regarding the risks of miscarriage, intrauterine fetal death, intrauterine breast restriction, pregnancy-induced hypertension, and so on and so on. So the difficult situation is when you see the patient pregnant while on dialysis, and you can counsel her, tell her the facts that this is a stolen pregnancy. I mean, she is liable to complication. These are the facts. We can minimize this complication, but you expect that there will be some form of complication to the fetus or the mother. If this lady is not accepting this risk, you can terminate pregnancy. Yes, you can. Especially if the parameters, as we said before, especially if the starting point with pregnancy, there is significant hypertension, there is raised serum creatinine and proteinuria. The management during pregnancy is a team approach. Usually the obstetrician is doing his job only for monitoring the progress of pregnancy, the fetal condition, optimizing the circumstances for the pregnant lady. But the main role is the role of the nephrologist who is looking after this patient. Definitely we start the frequency of hemodialysis to 20 hours per week. So this lady usually comes pregnant on dialysis 3 times every week, and the first move in this pregnancy is to increase to daily dialysis. So we used to do 6 times a week, or an average of 20 weeks per 20 hours per week. She was an angiotensin converting enzyme inhibitor, which is not good for the baby, so we move to albumin or alpha-methyl. We are aiming to keep the blood pressure around 40/90. We can give iron therapy to correct anemia. Corticosteroids should not stop during pregnancy. We can go on corticosteroids with no adverse effect. Antenatal visits, we should monitor this patient more closely than the average. So if we see every month in the first 28 weeks, usually in pregnancy we see them every 2 weeks. And usually I'd say you need to see the nephrologist 1 week and to come to the obstetrician the other week. So every week she sees a physician, in addition to every day dialysis. So it's very close monitoring of these patients. You need to keep the blood pressure under control, correct anemia, and all these correctable factors. But what happened all of a sudden? This lady developed severe pain in the abdomen, rupture of membrane, and she delivered the baby who later died. Although she was fine early in the evening, by 2 a.m. that night, about 6 hours later, she just developed severe pain, rupture of membrane, and she's going to deliver. So you ask yourself, why this happens? Why she's getting a placental abruption, or we call accidental hemorrhage? That's the effect of the systemic lupus erythematosus. This can happen only with systemic lupus, even without renal disease, but definitely with renal disease, the situation gets worse. So that's the classical outcome of the patient on dialysis, on renal failure with underlying systemic lupus. That's a case which more or less illustrates the fact that pregnancy while on dialysis or end-stage renal disease is associated with many maternal and fetal adverse effects. And now we can avoid that by planning pregnancy after stabilization of the graft. We usually say 2 years, but Dr. Hussein used to say 1 year after a successful graft is okay. So after 1 year of good functioning graft, the lady can get pregnant, and if the creatinine and blood pressure are normalized, we can guarantee a success rate or a take-home baby in over 85%. And usually they deliver by cesarean section. But Imran, as I said, brain, corticosteroid, all these are quite safe during pregnancy. You shouldn't be worried about that. And the woman carry on her medication and get usually a healthy baby. All that is caused by the physiological changes of pregnancy, because during pregnancy the glomerular filtration rate and the renal blood flow increase by about 50%. So say if she's going normally by creatinine around 2, okay, and consider the mild renal impairment, once she gets pregnant, the blood flow to the kidney is doubled. So the kidney could not cope with, and in a short period, her creatinine would be doubled. So all the physiological changes of pregnancy add stress on the kidney function. Everything increases. In normal circumstances, there is washout and creatinine and blood nitrogen gets down. But in pregnancy, the kidney size also increases. So now, with this background, what are the changes? What are the chances of pregnancy in women and that? I would say there is no chance of women with chronic renal disease without dialysis or successful dialysis, without transplant, of having even periods, and there is no chance of getting pregnant. So even diabetic lady before the era of insulin, they never get periods and they never get pregnant. Before hemodialysis or peritoneal dialysis, before that, and before renal transplant, these women who have creatinine of 4 or 5, they usually don't have periods, don't have ovarian function, and definitely they never get pregnant. But now, with dialysis, they can get pregnant. And definitely with transplant, they can lead a normal life. These are the questions that we're going to answer. Fertility, as I said, is significantly reduced in women with end-stage renal disease. About 40% of women on dialysis get regular periods. Perhaps now this ratio may get a bit better than 40%. We sometimes see around 2/3 of women on dialysis getting periods. We say even fertility in women is about 0.5% per year.